Welcome back guys. Now in this video let's discuss about cervical incompetence and APLA syndromes. What exactly is cervical incompetence? In the name itself it's very clear that cervix is incompetent. Okay, cervix is getting dilated. Okay, the cervical os is getting dilated. If cervical os is getting dilated means, do you think that pregnancy will continue? No, definitely that will cause abortions. So important MCQ is that cervical incompetence is the most common cause of a second trimester recurrent abortions. So it's the most common cause of second trimester recurrent abortions. But do you guys able to remember what is the most common cause of recurrent abortions? The most common cause of recurrent abortions is idiopathic. Okay. Now see, this cervical dilation will be painless. Okay, the cervical dilation is going to be painless dilation. Okay, that's a very important point. It's not the painful, it's a painless dilation. So what is the criteria for diagnosing when we can say that this is cervical incompetence? See, if there is 2 or more consecutive pregnancy losses. Okay, so if there is 2 or more consecutive pregnancy losses, especially in the second trimester, then you can suspect, okay, that these abortions are because of, because 2 consecutive or more. So now you will be suspecting that these abortions are because of cervical incompetence. Now later on we will see how we will diagnose, how we will come to the the diagnosis that this is cervical incompetence. But what is the criteria to say that this female is having cervical incompetence? Now she should be having at least 2 or more than 2 consecutive pregnancy losses in the second trimester. Now let's see what are the causes of cervical incompetence. Having a short cervix, that too less than 2.5 centimeters. Short cervix means a cervical length less than 2.5 centimeters. Such a short cervix can easily efface, easily dilate. Okay, just with a very little pressure it can simply dilate. So dilatation of that cervix can lead to abortions. Okay, now short cervix, repeated dilation and curettage, 𝗠𝐞𝐝𝐢𝐻𝐿ization and trachelectomy. So 𝗠𝐞𝐝𝐢𝐻𝐿ization, 𝗠𝐞𝐝𝐻𝐿ization we usually do for cervical cancer. Okay, for the first stage of the cervical cancer we will be doing the 𝗠𝐞𝐝𝐻𝐿ization, or for diagnosis also we can do the cone biopsy. Or for trachelectomy, trachelectomy is a surgery where we'll be removing only the cervix. Okay, it's a fertility preserving surgery. In the topic of cervical cancer also we have discussed that we will be doing the radical trachelectomy. Okay, now any surgery which is done with the cervix is a risk factor for cervical incompetence. Cervix is getting dilated painlessly, that leads to second trimester abortions. Okay, usually this abortion happens when 16 to 24 weeks. Okay, this is the time period which usually this cervical incompetence happens. Now please concentrate how to put the diagnosis. Now we are talking about diagnosis. See, in a non-pregnant woman, you are suspecting that this female is having cervical incompetence. Then how you are going to put the diagnosis? In a non-pregnant female, what I will be doing is, I will pass number 8 𝗂𝐬𝐼𝐻𝐿ization dilator. If I pass the 𝗂𝐬𝐼𝐻𝐿ization dilator, okay, there is this instrument called as 𝗂𝐬𝐼𝐻𝐿ization dilator. You can see here. This is number 8 𝗂𝐬𝐼𝐻𝐿ization dilator. If you pass that 𝗂𝐬𝐼𝐻𝐿ization dilator into the cervix, if this dilator passes without any resistance, very smoothly if it's going, means that this cervix is an incompetent cervix. Okay, now this dilator is easily passing, so the cervical os is getting easily dilated. So if there is a pregnancy, definitely that will end up as abortion. Okay, why? Because the cervix is incompetent, it is easily getting dilated. Okay, or if you perform cervicography, you will see Y or V shaped, the cervical cavity. Usually the cervix should be something like this. Okay, the cervical cavity, it should be something like this. What happens if it is getting dilated? If it is getting dilated, see, the shape is getting Y shaped, or it can become a V shaped, and sometimes it can even become U shaped. So upon doing hysterocervicography, if you see V shape, Y shape or U shape the cavity, so that is a diagnosis for cervical incompetence in a non-pregnant female. See, in a pregnant female, you are not supposed to put the 𝗂𝐬𝐻𝐿ization dilator. Why? Because if you put the 𝗂𝐬𝐻𝐿ization dilator, definitely that will end up as abortion. So in a pregnant woman, what we can do to put the diagnosis of cervical incompetence. What we can do is ultrasonography. So on doing ultrasonography, if you see the cervical length less than 2.5 centimeters, okay, if the cervical length is less than 2.5 centimeters, now this is an incompetent cervix. If you won't manage it, it will end up as abortion. Or internal os has dilated more than 2 centimeters. If the internal os has dilated more than 2 centimeters, now this is an incompetent cervix. Now you have to do certain management. You have to intervene. Okay. Now what we can do, we will discuss. See here, this is what we can do as a management. See, we are going to put a cervical cerclage. Okay, the most common cerclage which we are going to put is McDonald's cerclage, which is preferred. Okay, McDonald's cerclage is a more preferred one and it is the most commonly used one. What exactly is cerclage? See, cervix is getting dilated, right? What we are going to do is we are going to put a sutures. Okay, we are going to put a stitches so that cervix won't dilate. That's what is known as the cerclage. McDonald's cerclage, most commonly used one, most preferred one. But best cerclage is 𝐒𝐻𝐼𝐴𝐻 cerclage. Here what you can see is like, these sutures which are like just like a purse slip. Okay, purse slip. Okay, there are that kind of purses where you just try to like extend this thread. The lip of the that opening of the purse is getting closed, so like that. Okay, so this is purse lip like suture. Okay, purse like sutures. So this is whatever you are seeing here is a McDonald's cerclage, which is most preferred used one, but the best is going to be 𝐒𝐻𝐼𝐴𝐻 cerclage. Now question, when we have to put the cerclage? When? Now pregnancy has diagnosed, you have also diagnosed that this cervix is an incompetent cervix. You have diagnosed it. Now when to put the cerclage? In the first trimester, second trimester, or when? You have to put this cerclage especially in the 12 to 14 weeks. That's the second trimester. Actually you are applying the stitches in the second trimester, 12 to 14 weeks. Why not first trimester? See, putting this first trimester, actually the cervical cerclage, or I should say something like this, cervical incompetence is going to cause the second trimester recurrent abortions, not first trimester. Okay, so we are putting these sutures in the second trimester. Or remember, see, in the first trimester, the most common cause of spontaneous abortions is chromosomal abnormalities. Am I right or not? Yes, the most common cause of spontaneous abortions is going to be a chromosomal abnormality. Now this baby, whatever is there right now in this current pregnancy, might be having some aneuploidy. Okay, so it will be automatically terminated, it will be automatically aborted. So if you put the stitches in the first trimester, actually you are saving a baby which was about to abort. This baby should be aborted. Why? Because there is some chromosomal abnormality. So definitely this baby should not survive. This baby should be aborted. So if you put sutures in the first trimester, actually you are trying to save the baby. So you are saving a baby which is supposed to be aborted. So don't put cervical cerclage in the first trimester, put it in the second trimester. Apply the cervical cerclage in the second trimester. It's 2 to 14 weeks. Okay, in the time period of 2 to 14 weeks. And when the cerclage should be removed, the cerclage should be removed by 37 weeks. Okay, so after 37 weeks, once the term is attained, then you can remove the cerclage. Okay, so this is the management of the cerclage. Now what are the indications of cerclage? Okay, in whom we have to actually put the cerclage? See, there is this female with the history alone. What exactly I mean by history? There is this female who is having second trimester recurrent abortions. Just history is there, but you have looked for the cervix, you have done the ultrasonography, but the cervical length is good. Are you supposed to apply the cerclage? Yes, you can. Okay, there is this female with the history alone, but cervix is normal. Yes, you can apply the stitches. Okay, now there is this female with the history as well as the short cervix. Can you apply the cerclage? Yes, absolutely, you can go with the cerclage. Okay, now what exactly is rescue cerclage? There is this female. Okay, there is this female. There is no history. Okay, there is no history of second trimester recurrent abortions, or there is no history of cervical incompetence. Now she came to the clinic. Now you have examined that the baby's amniotic cavity. Okay, the amniotic cavity is almost coming into the vagina. Okay, the amniotic cavity have passed the cervix and right now it is in the vagina. Now what you can do, you should be able to save this pregnancy. So put back the amniotic cavity and try to apply the stitches. So this is rescue cerclage. Okay, so these are the indications for the cerclage. History alone, yes, it's an indication. History alone plus short cervix, it's an indication. And rescue cerclage can be done. Okay, now please concentrate. There is this woman with a short cervix, but there is no history. Only short cervix is there. Okay, she came to you for just general regular examination. You have found out her cervix is very small, short cervix, less than 2.5 centimeters is there, but there is no history of recurrent pregnancy losses, second trimester recurrent pregnancy losses is not there. So there is no need to apply cerclage MCQ. Just short cervix alone is not an indication for cerclage MCQ. Okay, so indications of cerclage are completed. What are the contraindications of cerclage? When cerclage should not be applied, when the sutures are not to be applied. See, there is presence of gross anomaly of fetus. See, the fetus is having anencephaly. Okay, are you going to apply the cerclage? Definitely this baby could not be able to live. So if you put cerclage, it's no use. So whenever there is gross congenital anomalies, don't put the cerclage. If the dilation of cervix, if it is more than 4 centimeters, okay, the cervix got dilated by more than 4 centimeters, no cerclage. Vaginal bleeding, like if membranes are ruptured, placenta previa, or presence of any pelvic inflammations, in all these conditions, don't keep any cerclage. Okay, these are the contraindications. Now, after this, let's talk about APLA syndrome. Cervical, cerclage, cervical incompetence completed. Now, let's talk about a condition which also causes second trimester abortions. That is APLA syndrome, APLA syndrome, or antiphospholipid antibody syndrome. Generally, let me tell you what exactly is the problem here. Here the main problem is formation of thrombus in the placental blood vessels. Okay, thrombus is getting formed. Actually, this APLA syndrome is a acquired thrombophilia, thrombus loving, actually thrombus forming condition. Okay, abnormally thrombus are getting formed. In this condition, there are certain antibodies called as anti-cardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein antibodies. These three type of antibodies are present. Now we will see why there is formation of thrombus. But before that, also let's discuss about the, okay, now first let's discuss about the pathophysiology. Now see, actually this protein beta-2 glycoprotein, this is a very good protein. This beta-2 glycoprotein, it inhibits the platelet aggregation. It doesn't allow the platelets to undergo aggregation. Okay, that's something good. In APLA syndrome, what exactly is happening? There is this anti-beta-2 glycoprotein antibody production is happening. If anti-beta-2 antibodies are getting produced, what happens? Now, platelet aggregation will start to happen. Yes, right? So beta-2 glycoprotein is getting attacked by the antibodies. Now, if beta-2 glycoprotein is getting attacked, it's not functional, automatically platelet aggregation will happen, and that platelet aggregation will cause thrombus formation. So, thrombus formation in placenta. Okay, we are mainly concerned about the obstetrics. So, thrombus formation in placenta will cause placental insufficiency that causes death of the baby, that causes abortions. Okay, now let's see what are the complications which are seen with the APLA. The complications include abortions, especially in the second trimester, preeclampsia, intrauterine growth restriction, or intrauterine death. Okay, intrauterine death. Now let's see what is the criteria for putting diagnosis of this APLA syndrome. Okay, the criteria is known as Saparo's criteria. Okay, Saparo's criteria. Now here at least you need one lab and one clinical criteria. One lab and one clinical criteria is needed. Let's see what are the clinical criteria. Now let's start from the second one. More than 3 pregnancy losses. More than 3 pregnancy losses before 10 weeks. Okay, before 10 weeks previously. There are more than 3 pregnancy losses. That's the clinical criteria for diagnosing APLA syndrome. Or after 10 weeks, one pregnancy loss with a morphologically healthy fetus. Morphologically everything is perfectly alright, but the fetus is gone. Happening after 10 weeks. After 10 weeks, loss of one morphologically normal fetus, or before 10 weeks, loss of 3 or more fetus before 10 weeks. Okay. Now, apart from that, there is a history of preterm delivery secondary to or because of severe pregnancy induced hypertension or uteroplacental insufficiency. Because of pregnancy induced hypertension, because of preeclampsia, if there is a preterm labor in the history of this female, that can also be taken as a criteria, okay, clinical criteria for diagnosing this APLA syndrome. Or history of arterial or venous thrombosis. History of venous or arterial thrombosis, or I can say 3 pregnancy losses before 10 weeks, or 1 pregnancy loss after 10 weeks with a morphological normal fetus, or history of preterm labor because of pregnancy induced hypertension. So if you have any one of them, it is a criteria for diagnosing APLA syndrome, okay, antiphospholipid antibody syndrome. Now, laboratory criteria include, you should be able to find at least lupus anticoagulant antibody, anticardiolipin antibody, a beta 2 microglobulin antibody, or this beta 2 microglobulin antibody is also known as beta 2 glycoprotein, okay, antibodies against the beta 2 glycoproteins. If you have to find any of them, one from clinical criteria, one from laboratory criteria is needed. Okay, now let's see the treatment. How to treat APLA syndrome? We have seen how to treat the cervical incompetence. Cervical incompetence will be treated by putting a cerclage, okay, McDonald cerclage or 𝗪𝐴𝐺𝐻 cerclage, okay, that's okay. Now, how to treat this APLA syndrome? Now, the treatment in pregnant female. Now, right now she is a pregnant. Now, what I can give her is heparin and aspirin. Heparin along with aspirin. So, aspirin doesn't allow the clot to form in the placenta, so that can prevent the abortion. Okay, see, this is we are giving in the pregnancy. Now, if she is a non-pregnant female, the best drug will be warfarin. Why? Because we all know that in pregnancy, warfarin should not be given, especially in the first trimester. Warfarin should never be given. Why? Because warfarin, it crosses the placenta, it causes embryopathy, that is fetal warfarin syndrome. Fetal warfarin syndrome, where the baby is going to develop brachydactyly, okay, short fingers, brachydactyly, nasal hypoplasias and stippled epiphyses, okay, that musculoskeletal abnormalities can be seen. Okay, so warfarin is given in a non-pregnant female for treating APLA. Okay, APLA is not something which is only present in the pregnancy. APLA can happen even in a normal female. So for preventing thrombus formation in her blood vessels, we can use warfarin. But in pregnancy, as warfarin causes embryopathy, we are not using warfarin, but we are using heparin with aspirin. Now, let's see, okay, a few important points. See, when we have to start the treatment, yes, we have discussed that in pregnancy we have to give the heparin as well as aspirin. From when we have to start this? Start treatment immediately after pregnancy is confirmed by urine pregnancy test. You have to actually stop the aspirin. Okay, stop aspirin 5 days before delivery. Okay, 5 days before delivery you have to stop the aspirin, otherwise she will bleed and she will die. Why? Because this aspirin is actually a blood thinner, okay, which doesn't allow the platelets to aggregate and which doesn't allow the blood to clot. Okay, so if you do the C-section with aspirin, she will die, right? So stop aspirin 5 days before delivery, and you have to stop heparin just 12 hours before planned elective C-section or planned induction for normal vaginal delivery. Okay, so stop aspirin 5 days prior, stop heparin 12 hours before planned induction of labor or planned C-section. Now, note, warfarin should not be used in the first trimester of pregnancy. Yes, we have already discussed that. But please concentrate, instead of warfarin, what exactly we are using? We are using heparin. Okay, aspirin plus heparin we are using. But heparin is not as strong as warfarin. So, after giving heparin, if she is developing thrombotic complications, see, pregnant female, you have kept her on heparin, okay? In the first trimester, you have kept her on heparin. But this heparin is not effective in her. Now she is developing thrombotic complications. Now what to do? Wait till second trimester. So from the second trimester, replace heparin with warfarin. So from second trimester, you can use warfarin. But in first trimester, don't give warfarin. So replace heparin with warfarin from second trimester. We have completed all the important points about the cervical incompetence and APLA syndrome and their management. Hope the video is helpful. Thank you.